All right, we are at the top of the hour, and I want to welcome everyone to the call. Good afternoon. I'm Valerie Weber. I'm your moderator and host for today's community conversation. I serve as the Community Impact Director here in Akron, Canton, and Youngstown with the American Heart Association. So today we will discuss COVID-19 and what those living with cardiovascular disease should be aware of amid this ever-changing pandemic. We're also going to have a conversation around COVID-19 for the general public and resources available as we all navigate this health challenge together. So a warm welcome to each of you, and thank you for joining us today. So as we begin the conversation, please feel free to use the chat option, and you can send comments or questions our way as this conversation evolves today. We're going to have a Q&A toward the end of today's session. And we also plan to have additional spin-off community conversations in the future to help address questions and expand upon our conversation here today. I am pleased to introduce our panel of experts and would like to take a moment to thank each of our panelists for taking the time today to bring their expertise to this community conversation during what is a very challenging and busy time for everyone. So I'm happy to introduce Dr. Justin Dunn, cardiologist at Summa Health and board president of AHA Akron Board of Directors. Dr. Daniel Newton, cardiologist and director of cardiac catheterization lab at Worcester Community Hospital and board president-elect of AHA Canton Board of Directors. Dr. Nicolette Poe, assistant professor of health professions at Youngstown State University and board member of AHA Youngstown Board of Directors. And Kathleen Smith-Grzyk, national vice president of community impact delivery here at the American Heart Association. So thank you all so much for being here, and thank you to our guests as well. So we're gonna go ahead and get right into it. Our first question is for Dr. Dunn. So Dr. Dunn, it has been reported that those with pre-existing conditions may be at higher risk for contracting COVID-19 and experiencing complications. What specifically should heart disease and stroke patients and survivors know about COVID-19 and their risk?
Well, thanks, Valerie, and thank you to the AHA for having me, and thanks to everyone for being on and participating. Hopefully this will be informative for everyone and a nice discussion. So the question, for everyone here, I know that a lot of people on the call are somehow associated with cardiovascular disease work as a healthcare provider, or possibly a survivor of heart attack or stroke, or someone with cardiovascular disease. So, this COVID-19 virus is something that we're learning more about every day, and we try to learn from the experiences of other countries as we start to accumulate more data. One thing that we have noticed is that this virus seems to adversely affect people who have comorbidities more than others. And one of those comorbidities that seems to be one of the highest risk factors for having an adverse reaction to the virus is cardiovascular disease and heart disease. Chronic kidney disease, lung disease, those are other comorbidities that seem to lead to worse outcomes if you are infected with the virus. So if you do have heart disease, if you are diagnosed with heart disease, or you work with patients that have heart disease, what are some things you can do to minimize your risk? In addition to the social distancing and protecting yourself, the general public measures that we're using already, heart disease patients have to be even more diligent about protecting themselves, maintaining that distance from anybody that might have been exposed. Certainly if you have other risk factors, if you're over the age of 65 or have multiple comorbidities, you really need to try to minimize going out in the public and exposing yourself. In addition to that, there aren't a lot of other things that stroke and heart attack patients really need to do other than the typical social distancing. A few things I'll mention in particular, though. One is around medications. There's been some discussion out there about stopping certain types of heart medications if you do get exposed to the virus or out of concern for making the viral infection worse. I would advise everyone to maintain their current medicine regimen and not stop any medications on their own. If you do feel that you want to stop your medications, please only do so with a long, lengthy discussion with your physician or cardiologist first before stopping anything on your own. Another piece of advice is just to try to live as healthy a lifestyle as possible at home. You know, a lot of patients aren't able to make it into the hospital for office visits. And so it's even more important now that you maintain a very healthy cardiac diet, keep your salt intake low, you know, keep yourself from getting pushed into volume overload and heart failure, as it will be difficult to get into a hospital and higher risk to get into a hospital to get treatment for that. And then maintaining a healthy lifestyle from an exercise standpoint. Everybody's kind of cooped up in their house these days, and it's difficult to find ways to get exercise. So I would just ask that everybody who does exercise and does live a healthy lifestyle to maintain that lifestyle as much as possible. Going out for walks outside, using exercise within your home, like climbing up and down stairs, and finding creative ways to do exercise without actually going to a gym. One thing I would advise around exercise, though, is if you don't exercise currently, you know, have a long discussion with your doctor before engaging in a very rigorous exercise program. If you haven't done it before, you want to ease yourself into that at this point. But those are some basic measures you can take to try to maintain your cardiovascular health in the setting of this difficult time.
Thank you so much, Dr. Dunn. We're going to toss it over to Dr. Newton. Is there anything that you'd like to add to what Dr. Dunn has said? And he did touch a little bit on the question about medications. And we have a lot of folks that are asking about specifically hypertensive patients being at greater risk and questions around their current medication and so forth. So any comments from you?
Yes, I'd like to pretty much echo what Dr. Dunn had said about the lifestyle modifications and trying to maintain your sanity by exercising. The concern that has come up recently is about specific antihypertensive medications called ACE inhibitors or ARBs. And the concern is that the COVID virus attaches to the ACE #2 receptor on a cell and gains access to the cell through that receptor. Once it gets in the cell, then it begins to unload its machinery, which then essentially takes over the cell's DNA and its ability to make it, make itself over and over again, multiple copies. So the theory is that if you're on ACE inhibitors or ARBs, that upregulates the amount of receptors on your cell and therefore causes the virus to gain entry much faster. More research has been done. It said that actually doesn't really play into it that much, and that actually if the virus does overwhelm the cell, there's too much RNA from the virus to co-opt the DNA machinery and make more cells. So the cell essentially dies and then gets absorbed by your body's own kind of vacuum cleaner cells and is removed. So that has now given way to not only not stopping those medications, but a new study at the University of Minnesota is actually testing that theory out by actually giving people ACE inhibitors and ARBs to try and see if that decreases the viral load that is created by the virus on these folks who get infected. So we've gone from concerns about it to a study that's actually going to try and see whether it decreases the infectivity of the virus. So long and short of it is, it's a lot of biochemistry, but long and short of it is that if you're on medications and your blood pressure is optimized, that you should stay on those medications, specifically ACE inhibitors like lisinopril, anything that ends in the word pril, or ARBs like losartan, candesartan, those medicines that end in the sartans. Obviously, you need the guidance of your physician. If you are come into the hospital and you're sick and you're hypotensive, then these medications obviously are designed to lower your blood pressure, and so that could cause complications as you are recovering from this. As far as the other antihypertensive medications, the recommendation is to continue to take those under the guidance of your physician and not adjust those in any meaningful way. To also underscore what Dr. Dunn was saying about sort of the unique lifestyle that we've had to forced to adopt over the past few weeks or so, and conceivably for the next few weeks, is figuring out a way not to have severe cabin fever and go crazy. Fortunately, as spring is coming, there's more opportunities to go outside. And I would encourage people to, take up hobbies, read books that they've been trying to read, go on walks on a daily basis, obviously with the cautions of not congregating. There's communities that come out at a certain time every night and converse on the sidewalk with each other, things that would have never happened without this virus sort of changing our lifestyles. And so there's been some positive components to it. But certainly if you have any questions about your medications, obviously consult your physician and get some guidance from them.
Thank you so much, Dr. Newton. So if anyone has additional questions from some of the things that they heard from Dr. Newton or Dr. Dunn, please do enter those into the chat. There is a chat option at the bottom of your screen. So we are going to head over to Dr. Poe. Dr. Poe, to touch on ways the public can protect themselves as we continue to maintain social distance, stay at home, and practice proper hand washing and keeping frequently touched surfaces clean. We also saw that the CDC recently recommended the general public to wear cloth face masks. What are your thoughts, and when should they be worn?
Okay, well, first I want to say thank you to the American Heart Association for this opportunity to participate in this important event to keep our communities informed. And I want to remind everybody that we are all in this together. As you mentioned, CDC has developed recommendations regarding the use of cloth face coverings, especially in areas where there's significant community-based transmission. And so because CDC continues to study the spreads and the effects of this virus across the United States, we now know that recent studies have show a significant portions of individuals with this virus may lack symptoms or be considered asymptomatic. And so therefore, even of those who do develop symptoms, what we're finding or be pre-symptomatic can transmit the virus to others before showing symptoms. And so this means that the virus can spread between people interacting in close proximity. For example, it could be something just simply speaking, coughing or sneezing, even if those people are not exhibiting any symptoms. So in light of this and the new evidence that CDC has recommended, this supports their recommendation of wearing cloth face coverings, especially in public settings where we also are encouraging social distancing measures. So we want you to maintain those social distances during these difficult times, especially when you're out in the community like grocery shopping or going to get your pharmacies, or especially in areas where there's opportunities for community-based transmission. The thing I want you to think about here though, it is critically important to emphasize the importance of maintaining that 6 feet social distancing. This is still in place in addition to wearing the cloth face coverings. These actions are important and will help to slow the spread of the virus. Most importantly, CDC has offered some additional advice in regards to, how by simply using the face coverings can help slow the spread of the virus, as well as help people who may have the virus and may not know it and be transmitted it. So that's why this cloth face covering fashion that you can use items in your household, you can make it at home, are very common and it's low cost. And I encourage people to really consider following CDC's guidelines. And this is a voluntary public health measure that we all can do. Most importantly, I want to make this clear that the cloth face coverings are recommended, we're not talking about surgical masks or the N95 receptors. We're not talking about those masks. We're just talking about, those types of supplies should be left for and reserved for our healthcare workers and other medical first responders who are dealing direct and providing direct care. And so, again, these new recommendations are in support. They ultimately complement what the president's coronavirus guidelines have in place for America in regards to 30 days, this whole movement to 30 days to slow the spread. And I know that we all can work together to do our part to help with this major public health crisis.
Thank you so much, Dr. Poe. And I do have a follow-up question for you that just came through. Someone's asking, do you recommend, or what are your thoughts on masks being worn when we're taking walks or just in public where others may be present? Any comments on that?
I think the key thing here is that if we practice both at the same time, I think that creates an opportunity for us to be respectful to others and also help slow the spread. So the key thing is you really want to make sure if you're keeping that distance, and if you are out and about, having things that could cover you in an event, ideally you go for a walk, you don't intend to interact with people, but that may happen. So you want to take those precautions and bring those things with you and be covered. I think the key thing here is be reasonable and practical. If we follow just the basic pieces of, how we keep ourselves healthy, I think in general that will help us move forward.
Thank you so much. So next question is, yep, please do.
Sorry, just to I agree with everything Dr. Poe said, just to kind of build on that and to answer the question as well. These masks that the CDC recommends we wear, cloth masks, or homemade masks. The primary intent of these is not to protect the wearer from the virus, although it may provide some protection from droplets, etc. The main intent is to prevent asymptomatic spread to others. So if somebody does have the virus and not know it, the recommendation is that everybody wears some type of covering so that when they do go in public and interact with people, they're not accidentally spreading that virus to others who may be at higher risk than them. So, there are a couple of different types of masks. One is this mask that everybody's recommended to wear, like a cloth mask or maybe even a surgical mask if you work in a hospital. And then there's this talk of these N95 respirators, which do provide protection to the person wearing the mask. And that's why those are reserved for healthcare workers who are interacting with patients that may have the virus. So again, it's a little bit confusing. People think that a mask will provide them full protection, but it actually, they still need to, like Dr. Poe said, they still need to maintain the social distancing because it's more to prevent them from spreading the virus rather than protecting them individually.
Thank you so much. Our next question, we're going to head back over to you, Dr. Dunn. We understand that testing is ramping up here in the state of Ohio. With that said, who should be tested and when?
So testing is a difficult question. This has been a hot topic in the news. Everybody asks about testing and the availability of certain tests. There are essentially two different types of testing that when we talk about testing. One is testing for the active virus, so testing for somebody who's actively infected. This is the nasal swab that you may have seen, where they swab your nose or your mouth and try to identify through processing of certain proteins whether or not the patient is actually infected with the virus. So this helps with patients who come in who might have symptoms or might have been exposed, who we are trying to then place into isolation or get into treatment early and move them from the active infection into recovery and minimize the spread of that virus to other people, especially healthcare workers in the hospital. The other testing people talk about is this antibody testing, or in this rapid testing, which is, I think, what more people are talking about these days. This is the testing where you test a random person or somebody who may have been exposed or may have had the virus, and you look for antibodies to that virus, which are a sign that the patient has been exposed and has recovered from the virus. So the main reasons for that would be to reintroduce people back into society, so back into the workforce. If somebody has antibodies to the virus, there is a very, very high chance that they will then be somewhat immune from the ill effects if they were to be exposed to the virus again. We don't know for sure, but based on previous experience with viruses and the way antibodies work, if you do get exposed to the virus again, there is minimal chance that you will then get sick. And the reason that's important to to spread to the general public is that you can then test people who are asymptomatic and say, look, you've been exposed to the virus. You're probably one of the people that can get back to work. Another reason to test people for antibodies is for possible treatment. There's this convalescent serum, convalescent plasma that you probably heard about in the news, where people who've been exposed to the virus that now have antibodies may be able to donate that to people who are ill and shorten their course or provide treatment for patients. So that's the impetus behind trying to rapidly get a quick spread of the antibody test out there. So those are the two different types of testing. As far as who should be tested with the nasal swab, we have limited numbers of these, and we basically only test patients who come in with symptoms, who look like they have the virus. We haven't started testing people on a widespread basis based on limited ability and limited number of tests. But essentially, if you think you have symptoms, you talk to your doctor, and if you have symptoms that are concerning, you have to come in, and usually in the hospital setting is where you get tested for an active virus, and then they can triage you to the appropriate place.
Thank you, Dr. Dunn. Next question, we're going to head over to Dr. Newton. So as hospitals are treating many COVID patients, there's a lot of folks out there that have fears around heading to the hospital for non-COVID related issues. If someone begins to notice symptoms of heart attack or stroke, for example, we know that time is of the essence, but some are hesitating to call 911. Can you comment on that? And what should the public do if they find themselves in this situation?
Yeah, that is a very good question, because obviously this virus, this situation, this pandemic is sort of driving us to do the opposite of what we usually do as caregivers. We're trying to figure out ways to prevent the virus from entering into the hospital and exposing the hospital, the personnel, and other patients to this because of its how contagious it is. It's several times more contagious than the flu. And so we're trying to do testing outside, do drive around testing, and then that obviously gives way to, if you're having a heart attack or think you may be having a heart attack, what should one do if the recommendations are to stay away as much as possible from the hospital? I would recommend that if you are having chest pain, chest heaviness, shortness of breath, pain radiating down your left arm or to your back or your neck, all the kind of classic signs that you're having an acute myocardial infarction, which is a acute cutoff of blood supply to a major artery of your heart, that you engage 911, call them, do not drive yourself to the hospital, do not have anybody else drive you to the hospital, but have the ambulance come. Now, many ambulances these days, in fact, most, have the ability to do an EKG at your home. And they can then transmit that to the emergency room, where a physician, either an ER physician or a cardiologist, can review it and determine the severity of your symptoms and whether you're truly having an acute heart attack, at which time then they would most likely bring you to the hospital for further care. Remember, as challenging times that we live in, and as scary as it is with the virus, having an acute heart attack, your likelihood of dying is far higher than the chance of catching the virus under controlled situations where you're protected with the hospital care workers, protecting themselves from you and you from them with masks and gowns and all those other things. So I would encourage people, if you're having severe symptoms like that, that you call 911, that you get assessed emergently, and that they bring you to the hospital. Now, as far as what happens there is a different question, which we can go into. I'd be happy to answer those questions, because that, usually if you're having a heart attack, in interventional cardiology, we use the term time is muscle. So the more time that goes by, the more muscle you are losing, and the potential for irreversible permanent damage or arrhythmias that can deteriorate and cause you to your heart to quiver or to stop altogether, and obviously pass away without intervention from hospital staff. So upon arrival to the hospital, then we have to figure out what we should do. And the various options are, if you're not having an acute heart attack, The triage would be for medical therapy with blood thinners, anti-blood pressure medications, and time to sort it out. As far as the extreme cases of an acute heart attack, many years before we had primary PCI, which is emergent angioplasty, and going to the cath lab, we gave aggressive blood thinners, what are called thrombolytics, which dissolve the clot acutely and try and open up the vessel and reperfuse the artery. We learned from many, many years ago that is sometimes hit or miss, and that patients did better with aggressive primary PCI, which is emergently taken to the patient to the cath lab. Now, in these days, with the pandemic going on, it is difficult to know without a rapid test in the emergency room whether or not a person has been exposed to COVID, whether they are infected and maybe don't know it, whether they're actually infected, and that's part of the reason why they're there. Those tests are coming online. You probably have seen in the press about the 5-minute test or the 10-minute test or 15-minute test versus sending the test out and waiting several days to get it back, which was the initial testing standards that we had at the very beginning of this crisis. So depending upon how severe your condition is, it may be determined that it might be best not to go to the cath lab, but rather to give you aggressive blood thinners to try and put the fire out, if you will, and stabilize the patient and hold off on doing that. I think that's an individual decision that has to be made between the patient, the family, the ER physician, the interventional cardiologist, and try and do what is optimal. Somehow have the lines intersect where what's best for the patient meets what's best for the hospital staff and the rest of the team, because if there is an exposure, those folks may have to be quarantined, which then can reduce the service line for other patients, and have aggressive cleaning measures and all that sort of thing. Getting back to what Dr. Dunn was saying about the mask, if I could for just a second, there have been some studies done that showed people how many times they touch their face, multiple times a minute. And it turned out that if you wear a mask, you are much less likely to touch your face over and over again. I don't know the mechanics of that or what, but the primary objective of all of these measures is to prevent the virus from gaining entry into your body. And the main entry sites are your nose, your mouth, and your eyes. So if there's a way to prevent that from happening, albeit, maybe not proven with randomized controlled trials with, having people wear masks and exposing them to virus and all that, there's no question that wearing a mask helps decrease your touching of your face. So I think that's part of the impetus for why the government has recommended those cloth masks. And also because 50% of people who have COVID are completely asymptomatic. They have no symptoms. So, half the population, if you will, or half the members who you hang out with may have the virus and may be able to give it to you, which is the purpose of the cloth masks, as Dr. Dunn said, is to prevent you from giving it to somebody else.
Thank you so much, Dr. Newton. So what I heard you say was, if someone does think that they are having a heart attack or a stroke, is to do what they would normally do and call 911 immediately. And, there was a follow-up question to that we just had come through with some of those fears that folks are having that are having non-COVID related symptoms. Are you all seeing, either a question for Dr. Dunn or Dr. Newton, are you seeing a reduction in patients that are presenting at the hospital for heart attack and stroke?
Yes, we are. Actually, there's an article that's been written just recently that was titled, "Where Have All the STEMIs Gone?" STEMIs are the acronym for acute heart attacks. And I think it may be a combination of people's fear of not coming in because they are afraid of entering into the hospital. It may be that their symptoms get better or that maybe they weren't, STEMIs to begin with. But I would encourage people, if they have those kind of symptoms, to not be afraid to enter into the hospital system, because we know that by not doing that, if you truly are having a heart attack and you have an arrhythmia at home, the chance of survival is very, very low. So I would err on the side of caution. All of the ERs are prepared for somebody to come in. They have, proper gowns, proper protection, and they will do their best to protect you from them and protect the rest of the staff from in any way infecting you. We are still here, 24/7 to serve. We are still taking patients, if indicated, to the cath lab with proper donning of protective equipment, because ultimately that person's life is acutely in danger. And virus being what it is, we have as best precautions as we can to intercept that person's heart attack and hopefully minimize what otherwise would be permanent damage or death.
Thank
And I would
you.
echo the same thing. I mean, we've seen a similar downturn in cases of heart attacks. It is, I think it's multifactorial. I think a lot of it is people fear coming into the hospital during these times and kind of tough it out at home, and maybe where they would have been more cautious and come in, they haven't been now. But I would echo what Dr. Newton says, and if you do have chest pain symptoms and you think you're having a heart attack, please do take the necessary precautions and call 911 and get checked out.
Thank you, Dr. Dunn. We're going to head back over to Dr. Poe. During this Tuesday's briefing, Ohio Health Director Dr. Amy Acton said it is vitally important for Ohioans to not let up over the next few weeks in regard to stay-at-home orders and following guidelines. She also said actions taken by the state and by Ohioans has kept the state below the hospital capacity line so far in flattening the curve. When looking at Ohio compared to other states, its curve is flatter. She said it's important to keep in mind that many states are ahead in their response in their curve than Ohio is. So this is why it's important that we heed this advice. So any comments that you have as far as that goes, Dr. Poe?
Well, the reality is these are difficult circumstances, and I understand there are many fears our communities are feeling, and so we know that this is a person-to-person contact. Therefore, taking the precautions is necessary. CDC and other federal, state, and local government agencies are working to prevent people from getting sick, and everyone can take steps to protect themselves and others during this outbreak. The virus is thought to spread mainly, again, from person to person, and recent studies has indicated that people who are affected do not have symptoms likely and also play a role in spreading this virus. And so therefore, what we know at this point in time, there's currently no vaccine to prevent this disease from spreading. So the best way for us to prevent illness is to avoid being exposed to the virus, obviously, right? And so therefore, we must all do our part to help slow the spread of the virus by listening and following the directions that the federal, state, and local authorities are putting in place. So the key things, and we've talked about it already today, like if you feel sick or your children are sick, stay home. If someone in your household is tested positive, keep the entire household at home. The key here is that we're avoiding social gatherings. We're washing our hands frequently. We're cleaning and disinfecting items and surfaces frequently. We're consuming fruits and vegetables and other foods that may help boost our immune system. We need to be physically active. We need to relax. Maybe perhaps over this time that we've had to be at home and enjoy our family and friends or the people that we live with, this has reduced some of our stress, which is important. This also gives us an opportunity to connect with our family and friends, ideally virtually, to keep that social distance in place. Most importantly, being able to get sleep. Being able to get at least 8 hours of sleep per day is great. And the other part, and we've talked about this already today, where we need to follow our doctor's advice and to help us avoid overwhelming our healthcare system. These actions and many others are necessary to help us flatten this curve of people being diagnosed and suffering from this virus. And so therefore, our goal is to reduce the caseload of the patients and also looking at how we can allow our healthcare system to effectively manage the demand that they currently have and that they anticipate could happen in the future. So the important thing here is that I want you to think about by following the state's guidelines is what we all can do now during this human emergency. We're hoping for a resolution, and most importantly, to learn from this experience. And in doing that, what we can do in the meantime is consider this: let's respect each other by continuing to follow these guidelines that have been implemented by the federal, state, and local and third authorities.
Thank you so much, Dr. Pozza. Great advice. We are going to head over now to Kathleen. And Kathleen, the question is, how is the AHA responding to the COVID-19 pandemic nationally and mobilizing our staff locally to help support communities?
Sure. So, you know, our mission at the Heart Association is to be a relentless force for a world of longer, healthier lives. So we really do feel called to play a role in addressing this pandemic. So we are doing quite a bit. At the national level, the association has established a $2.5 million rapid research fund to fast track scientific research so that we can better understand COVID-19 itself and its interaction with cardiovascular and cerebrovascular disease. We also have a really exciting partnership with the Lawrence Livermore National Laboratory that's been going on for a while. And through that partnership, the laboratory is using the technology that was created by the AHA Center for Accelerated Drug Discovery, specifically a drug discovery pipeline, scalable virtual screening, and machine learning algorithms to apply those technologies to a COVID-19 response. We're also teaching hospitals and communities how to safely and effectively administer CPR throughout this pandemic. That is a huge concern to people. And at the federal and state levels, we are working to ensure that families have access to care. There's been several relief bills. There are bills still in consideration, and we want to make sure that we can guarantee free coronavirus testing, increase manufacturing of protective equipment for our healthcare providers. We want to enhance federal nutrition programs, and then also increase Medicaid funding, all at the national level. And then at the state level, we're urging governors and state legislators to remove barriers to testing, encourage people to use caution, and then waive rules that require in-person interactions. For example, you know, as we're doing mobile pickup with students at picking up their food from schools to continue to address that issue, students no longer have to be there so that we can eliminate that one contact potentially. So at the community level, we have our staff on the front lines that have been, you know, really working to impact their communities in so many ways before the pandemic, and are really pivoting to make sure that we can work with our partners to ensure that we're continuing to nourish families. Like I said, as schools across the country's close, we're striving to support the countless school districts and other providers working to ensure that 30 million children who rely on school meals continue to have access to those meals. And then in some cases, expand that access beyond just the student to the family as well. We want to support physical activity, and I think I'll talk about that a little bit later. And we also want to continue to help reduce the burden of chronic disease during this difficult time. You know, hypertension, high cholesterol, diabetes haven't gone away. They still need to be treated, and we want to make sure that we're supporting our clinicians and patients to address those issues throughout the pandemic. And then finally, we're supporting early care and education providers to continue to provide high quality care, particularly for our healthcare providers and our frontline workers who still need childcare, and also providing them resources to address limitations in this challenging environment.
Thank you so much, Kathleen. Can you touch a little bit on the Healthy at Home initiative and resources for our communities?
Sure. I think, you know, AHA feels like we have a big role to play in making sure that as folks are safe at home, that they're also healthy at home. And if you go to our website at heart.org, on the main page, there's a big coronavirus box. You can click on a link that will take you to resources, not just about the virus itself and guidelines for patients with cardiovascular disease and other concerns, but we also have some tips around healthy, shelf-stable eating, because we know that is a concern right now, healthy recipes. And then for April, it's Move More Month. And we have launched Move More Together, which if you go to AHA or heart.org/move more together, there are all sorts of resources about how you can stay healthy and active at home. So some of those resources are fun ways to be active, how to make every move count. There's activity challenges, and even daily live workouts at 8 a.m. and 8 p.m. Central.
Awesome, thank you so much. And I know a few of our panelists touched a little bit on stress reduction. I know there's some resources around stress reduction. Can you talk about those a little bit? And we'll make sure we share all these resources with the group as well.
Yes, thank you for reminding me, because we do have a whole section on that coronavirus resource page about well-being and dealing with stress. You know, the stress of working from home. You know, as we all sit here, I just had to text my family to be quiet before I came off mute because they decided to have a discussion in the hallway right outside my office. We want to talk, there's resources about how to handle the anxiety that seeing all the news about coronavirus can have. Mindful eating, routines, cleaning up sleep hygiene. There's all sorts of great resources around dealing with the stress that this unprecedented time is bringing for us. And then also the other thing I will say that we have resources connecting to both CDC and World Health Organization resources around COVID-19 as well.
Thank you so much. So we're going to head into our Q&A portion. I know we just have a few minutes left of our segment here, and we may stay just a few minutes further with that if our panelists are able to do that. And so we'll see how quickly we can get through some of these questions. So we're going to open this portion up to all of our panelists. So our first question comes in chat. Is COVID-19 having any impact on patients' hearts? Someone in our community saw an article that stated that it was affecting the heart muscle, and she would like to know if there's any confirmation, if that's true or false, or if that's still being investigated.
It is still being investigated. You know, this is all anecdotal data. We're seeing things on a case-by-case basis. But yes, we have seen cases where a patient will come in with a documented case of the coronavirus, and they will, they have had some kind of damage to their heart. There are a couple different ways that can happen. One is the heart muscle weakens secondary to the heart muscle becoming inflamed. It's called myocarditis, and we've definitely seen cases of that associated with this virus, and we've seen it associated with other viruses as well. Whether or not that recovers, I think, is multifactorial. A lot of times it does. There's no guarantee, and I think time will tell to see if all these cases recover. But a lot of them have recovered. Another risk that we see with influenza as well is that these viruses can directly increase the risk of heart attack. They can cause plaque in the walls of the arteries to actually break into the bloodstream and cause a clot, which is the basic way a heart attack happens. We have seen that with the flu. That's why everybody who has any kind of risk factors for heart disease or has any heart disease is recommended to get the flu shot. And it is possible that that's a risk of the coronavirus as well. I think we're still learning more about that aspect of the virus's effect on the heart. But yes, it does have a direct effect, and how extensive that is and to what extent people recover is still up in the air.
Thank you. Our next question, what are the panel members' thoughts on when communities will phase back in integration and be able to have some of these orders lifted? And what would your recommendation be to people with cardiovascular disease or those that have a comprised immune system? Any comments on that?
I could comment on that as well. I guess the best way that we have for trying to get people back to work is through universal testing and getting these antibody tests out there. Dr. Acton said on Saturday that she is considering, once we get access to some of these antibody tests, she's considering randomly sampling 100 people in the community to kind of get a sense of the burden in the community. I think as far as reintroducing people back, I think you want to reintroduce people who have the antibodies and who are somewhat immune from the disease, and probably people who are lower risk. maybe people who do have the comorbidities that put them at higher risk, maybe they, still maintain the social distancing a little bit longer to prevent any kind of exposure to the virus.
Yeah,
Thank you so much.
If I can comment on that just for a second, it's going to be very challenging to try and get everybody to head back to work and normalize everybody's lives. As much as we would all love that to happen, I think we all have to be very cautious. This is not going to be like a thunderstorm or a hurricane that comes through, wreaks havoc, and then goes out to sea, and everything is going to get better, and you got to come back out of your houses. Remember, this is a worldwide thing. So as this spreads throughout the world, now going into the southern hemisphere, which is probably going to blossom into another urgency or emergency, and perhaps if this is a seasonal sort of thing, like many flus are, or many viruses are, there may be a secondary effect in the fall. For those who may have heard about the Spanish flu from 1917, 1918, the majority of the people who contracted it and passed away were not in the springtime when it started, but rather in the fall when it struck more severely and killed the majority of the people. That's not to say that this is how it's going to be with COVID. I'm not trying to suggest that. I think we have to be very cautious, and Dr. Dunn is correct. I think the only way to know for sure is to have universal testing, or as much as possible, for those who have either contracted it and done well and recovered from it, or those who were asymptomatic and may have antibodies, and then to perhaps do some kind of recruitment to those people who have antibodies to perhaps contribute or give those in a sample or in a way that will help people who are sick and have the virus, where they can give a blood donation, and from that blood donation, the serum can be extracted. And for every blood donation, you can get 3 quantities that can treat 3 patients of blood serum. And obviously those things are ongoing. And as far as testing antibodies, from my research or observations, it sounds like that's going to be several weeks away before we have any decent kind of antibody test that we can, with some assurance, know that you've had the virus and you can sort of go to work or go back to school or, rest assured. Now, there's some also who have commented that people who had the virus and got better then recontracted it, a small number of people. And that's sort of a question mark. How did that happen? Is this a different virus the second time around? Is it, what is the answer to that question? And we still don't know yet. From my reading, there was some who have said that the virus can mutate every 15 days or so, not severely, but perhaps in a way that may alter how we test or the test results. And remember, no test is 100% perfect. You may test negative and still have it, and you may test positive and be assured, but you still may have it. So those kind of questions, I think we have to be very cautious. As much as we want to get back to work and get back to normal, I think we have to be very careful because as we've seen, it spreads relatively easily. Just the words that I'm speaking right now, there's water vapor coming out of my mouth that if someone was sitting next to me, they could, incidentally breathe in. And so we really have to sort of take our time and hope that we can get back to work soon or back to normal soon, but plan for a prolonged, recovery from that or return to normalcy. It may take several months, even a year, to sort of get all this behind us. And so we have to sort of understand that the virus really dictates that. And we have to be safe so that we don't have to keep going through this month after month or every quarter or so. I hope that answers your question.
Thank you, Dr. Newton and Dr. Dunn. We're going to take just one more question, and I'm going to close. We did just allot 45 minutes to be conscious of our healthcare teams. So if you guys are able to stay on, please do so. If you're not, we completely understand, and feel free to hop off. So I'm going to take one more question, and any questions that are left in the chat, we will do our best to get those answered, and we will send that out with the resources to the group here. So the question is, what are the effects of non-essential surgery? Are you seeing an impact on treatment for patients waiting on heart-related surgeries? Any comments?
Yeah, this is, it's an excellent question. As we all know, elective procedures have been kind of postponed for a lot of patients. And, elective is non-essential is a relatively, it's a relative term. A lot of patients feel that their surgery is essential, and postponing it is not ideal, and it's not ideal for healthcare providers either. What we want to do is try to find a balance of, if we can push a surgery back or a procedure back a little bit without causing any harm and minimizing that patient's risk by coming into a hospital and being potentially exposed to the coronavirus, then we want to do that. We have seen a decrease in non-essential surgeries and procedures for sure. That was the recommendation of the state, and we've followed that. Whether that will have a major impact on a statistical scale, on a population scale, whether there'll be adverse outcomes from that, I think time will tell. We try to pick and choose the surgeries carefully and the procedures carefully that we continue to do, and we determine whether it's worth the risk of that patient being exposed in the hospital versus the benefit of the surgery. So, if we feel that the benefit of the surgery outweighs the risk, then we proceed. If we feel the risk of the coronavirus is too high for that particular patient and the surgery or procedure can be postponed, we try to postpone it as much as we can. So it's a great question, and it's difficult. These are difficult decisions, and we have to work with your healthcare provider, and we have to work with the patients and families and determine the best course of action.
Thank you so much. So we are going to close now, and I would like to thank our panelists once again for bringing your expertise and your time during this very difficult time to this community conversation. So thank you to Dr. Dunn, Dr. Newton, Dr. Poe, and Kathleen for being here today. We'd also like to send out a big thank you to all of our healthcare teams across our region. Your dedication and focus on the health of our communities is truly inspiring. We also would like to thank all of our local heroes that are putting their lives on the line to heal our community and keep us safe. The doctors, nurses, healthcare workers, first responders, grocery store employees, the list goes on and on. We see that you're working tirelessly and selflessly through it all, and thank you truly from the bottom of our hearts. We'd like to thank our listeners for being here today, and we will be emailing all resources discussed to the group, and we look forward to continuing the conversation as we plan future community conversations with your feedback and needs in mind. Thank you so much again, everyone, and stay well. Take care.